Hello and welcome to my channel. Today we will talk about the peritoneum. The peritoneum, once we reach the peritoneal level, so we're dealing with the abdominal cavity actually. Beyond, if we cut the peritoneum, we'll be dealing with the abdominal cavity. And the abdomen, please consider the fact that it extends in the inside the thoracic cage. So it has a part concealed by the ribs and the costal cartilages. Don't forget this. Actually, it conceals almost all whole organs, like the left hypochondriac region concealing the most of the stomach, like the right region concealing the liver. So we will be dealing with abdominal regions. And some prefer the four-quadrant map for mapping the abdomen, just by a vertical line through the umbilicus and symphysis pubis, and another line through the umbilicus perpendicular to this one, will give you four quadrants. And this is not as common as the 9-region map. The 9-region map, you need two vertical lines and two horizontal lines to divide the abdomen into 9 regions, as you can see here. The two vertical lines are the mid-clavicular lines. They pass through the mid-clavicle and down to the mid-inguinal region. Or the middle of the inguinal ligament, you can say that. The other two horizontal lines, there are a couple of lines, easy lines, like the one that passing at the lowest points of the thoracic cage, which is the lowest border of rib 10. This is called the subcostal plane. It's an L3 level. There is another line, easy line, between the top highest points on the iliac crest called the supracrestal. Passes through these points, supracrestal. Highest points of the iliac crest, between L4 and L5. But those of significance, clinical significance, the other two lines that we will go by. The first one is the transpyloric, as you can see here. The transpyloric plane passes through L1 level and tip of the 9th costal cartilage. See, it cuts the costal margin at the tip of the 9th costal cartilage, where it marks the fundus of the gallbladder. Transpyloric means it passes through the pylorus of the stomach, the first part of the duodenum. It passes through the pancreas as it goes up and to the left, and passes through the hilum of the kidneys. So it's of clinical importance, the transpyloric, this one. And the other one is the intertubercular, between the iliac tubercles on each hip bone. See this line, the intertubercular plane, through the iliac tubercles at a level of L5. Now, if you consider these two horizontal planes and these two vertical planes, you will end up with 9 regions map of the abdomen. The middle parts are the epigastric, the umbilical, and hypogastric, or another name is the suprapubic. And on the right and left, you have upper right and left hypochondriac regions, means beneath the cartilage, concealed regions to protect the viscera behind. You have the right and left lumbar regions, where you have the kidneys as a main feature, and the right and left iliac regions, and we will talk about main organs present in each quadrant. So this is the map most clinicians go by when examining the abdomen. In the right hypochondriac region, most of the liver, as you can see, this part was all concealed by the thoracic cage. In the left hypochondriac region, you have the spleen, you have the upper stomach, and the left lobe of liver. See that? In the right lumbar and left lumbar are the kidneys. On the right side is the ascending colon, on the left side is the descending colon. The iliac regions, the right side is the cecum and the beginning of the ascending colon and the appendix. The left iliac region is the descending colon and the beginning of the sigmoid or pelvic colon. The epigastric region, mostly by the liver, which is here right behind the anterior abdominal wall. This is exposed part of the liver, part of the left lobe of liver in the epigastric region. Part of the stomach hidden by the liver, as you can see here. This is the stomach. Umbilical region, you get coils of intestine. The suprapubic region, behind this symphysis pubis, there's the urinary bladder and the uterus in females, and coils of small intestine, as you can see here. We are studying this because when you start examining the abdomen, you know what's beneath your hands, for example, in palpation or percussion. Okay, so we will be dealing with the last layer of the abdominal wall, which is the peritoneum. Before we get to the peritoneum, there is an extra layer, external layer of extraperitoneal connective tissue that separates the peritoneum from the surrounding transversalis fascia, for example, and the diaphragmatic fascia. It's adherent to, it's part of the, covers the peritoneal sac, actually where it goes, condensed in some areas and thin in others. And I ask you, when you're dealing with the peritoneum, I want you to imagine that you have a closed sac, completely closed sac. Okay, so you can never go inside by either. The only ways to get there is by cutting a layer. Okay, represent this sac with the pink color here. This is the big sac, and you throw this sac on the lesser curvature of the stomach, and so part of the sac will be behind the stomach, this blue part, see? And I want you to cut the anterior layer, this one, and go using the posterior layer. You grab the part of the bag that was behind the stomach and pull it forwards, so you will end up holding 4 layered structure. You understand me? You know what I mean? Because you use the posterior layer of this parietal peritoneum to hold the other end of the back and pull it forwards. Actually, I'm pulling the greater omentum and the part of the bag that was behind the stomach. All this is the lesser sac. Okay? So, lesser sac, which is here behind the stomach, this is the lesser sac, is part of the cavities of the abdomen. The greater sac is all what you see in the abdomen when you cut the anterior layer of the parietal peritoneum. So when you look inside, all this is the greater sac, with all the organs either behind the peritoneum, retroperitoneal, or invaginated through the posterior wall to have a mesentery and become intraperitoneal. So these are intraperitoneal structures, but those are extra or retroperitoneal. Okay, you got the idea now. As you can see here, this is the lesser sac, and all this outside is the greater sac. The connection between them, see, through this foramen called the foramen of Winslow, epiploic foramen, from the lesser sac to the greater sac. Okay, other features of the peritoneum: it makes omenta, greater and lesser omentum. The greater omentum, the one we grabbed with our hands, the 4 layered structures that we pulled from behind the stomach. See, it attaches to the greater curvature of the stomach. It's full of fat. It's a fat reservoir, and its status depends on the nutritional status of the host. Sometimes it might be thin and translucent with scanty fat in it, and many times it's loaded with fat. Okay. It acts like a policeman of the abdomen because it adheres to areas of infection and make adhesions around it. So they call it the policeman of the abdomen. Localizes infection and forming adhesions. So now we understand the concept of the greater sac and the lesser sac and how they are connected through the foramen of Winslow. Another feature of the peritoneum, it forms mesenteries. I showed you, see, these organs, like this, in this case, the transverse colon, invaginated through the posterior wall and made and left a mesentery behind it. Double layered structure holding the organ at the end, see, enclosing the organ. So this organ is considered intraperitoneal and has an anti-mesenteric border and the mesenteric border facing the mesentery. The mesenteric border, of course, the border through which the vessels and nerves come to supply the organ, not the anti-mesenteric border. Okay. Another feature made by peritoneum, see those appendages, the yellow ones, full of fat. These are called the appendices epiploici. See those? They increase in number as you go distal to almost cover all of the sigmoid here. It's full of appendices epiploici. When was studied, it was found out that each balloon faces a site of entry of a branch of the blood vessel that supplies the wall of the large intestine. Okay, so I don't know the connection with that. Another feature you'll find made by the peritoneum is the recesses and gutters and pouches. When you cover something by a soft tissue and this thing changes its shape or direction, it will make folds in the covering tissue. The same with the duodenojejunal flexure, where you will find, superior and inferior folds, paraduodenal folds, and recesses. Why are you concerned with recesses? Because the recesses might be a site of internal hernia. A loop of intestine or so gets impacted inside the recess. Okay, and of course when it gets impacted it will be gangrenous, and it's a dangerous condition. Another recess, see here, this is the cecum, this is the ileum ending into the cecum. The cecum is slightly protruding inside the peritoneum, but not completely. The two layers don't unite behind the organ to make a mesentery. It has no mesentery, but because it protruded forwards like that, it has a recess behind it. It's called the retrocecal recess. Other recesses and folds because of the abrupt change in shape due to at the end of the ileum into the cecum. See the folds, the superior and inferior ileocecal folds and recesses with the probes inside. Sites for impaction of coil of intestine for internal hernia. Another thing, see the sigmoid, because it's S-shaped, it pulled a mesentery with it, and when you put your hands underneath this mesentery, you are in the intersigmoid recess. Okay, and it's, by the way, its apex is a landmark for the left ureter. If you go to the apex of the recess and press backwards, you are pressing on the left ureter as it descends. Okay. Also, you see the reflections of peritoneum to cover the large intestine, which are retroperitoneal, this part and this part. It forms gutters. See the gutter? These gutters are roads for spread of liquid, of infection, of exudate. So that's why post-operative patients in upper abdominal surgery patients, post-operative, they are put in the semi-sitting position to drain, especially if they worked on this area, to drain all the post-operative exudate through the passage through the foramen of Winslow to the lateral, right lateral paracolic gutter, and goes down to the pelvis. Well, they can reach it through the pouches downwards, the Douglas pouch and the rectovesical pouch. See, the Lisser sac opens to the hepatorenal recess, another pocket of peritoneum between the kidney posteriorly and the liver anteriorly. It reflects on the liver through the foramen of Winslow, and from that to the right lateral paracolic gutter, and from it to the pelvis, to the pouches, and these are the pouches. See, this is the rectouterine pouch of Douglas, this one, and this is the uterovesical pouch. See that? Narrow pouch. The point is, where when the exudate or infectious material accumulates in the pouches, you can reach it through digital vaginal examination. For example, in the posterior fornix, you are see very close to the pouch, where you can drain the pouch and relieve the patient. So this is the anatomical importance of this. Okay. Other features of the peritoneum are the ligaments and folds. For example, this is the inside of the anterior abdominal wall. The inside, you're standing behind the anterior abdominal wall from the inside looking forwards. So what we have here, see, this is this median fold in the peritoneum raised by the remnant of the urachus going through the umbilicus. This is the median, with an N, umbilical fold. See these two folds raised by the obliterated umbilical artery, that brought, that took away blood to the mother, and they are obliterated now. See that? Going to the umbilicus, raising the medial umbilical fold. Now you see these two. These are the inferior epigastric vessels. And if you can tell me where's the deep ring, yes, exactly lateral to it. The deep ring is lateral to it, right? It's raising the lateral umbilical fold. So you have two lateral folds, two medial folds, and one median fold. Another fold from the umbilicus upwards, see that? Runs in backwards, upwards and backwards in the free edge of the falciform ligament of liver. It's called the ligamentum teres, the obliterated umbilical vein. See, it makes a fold on the anterior abdominal wall, and I brought you this plate. This is more apparent here. See that fold? This is the ligamentum teres going backwards towards the liver in the free edge of the falciform ligament of the liver, and these are the folds we were talking about: the two lateral, the two medial, and the one median umbilical fold. You see that? And this is the urinary bladder, raising another transverse fold, as you can see here, with two fossae at the sides, paravesical fossae, all peritoneum made. And we will study with each organ all the peritoneal related subjects regarding that organ. Okay, another example are the of ligaments. On the left side, the left colic flexure is higher than the right colic flexure. It's because it's attached to the fascia of the diaphragm by phrenico or the phrenocholic ligament, only on the left side. Now, as you can see here in the liver, in the case of the liver, it invaginated the top of the closed bag, but not completely, but it is intraperitoneal, but the peritoneum did not unite completely behind it. See this? These are the margins of the cut peritoneum. You see the falciform ligament. This is the left triangular ligament, which is this one. This is the right triangular ligament, which is this part. And these two reflections are the limbs, anterior and posterior limbs, or superior and inferior limbs of the coronary ligament that encloses the bare area, a major bare area of the liver related directly to the diaphragm above. We will study this with the liver. Okay, so all these ligaments are examples of peritoneum in action. They are all folds by the peritoneum. Like, for example, if in a cut section of the body, as you can see in a CT, for example, this is the left side, sorry, and this is the right side. The stomach and spleen on the left. See, you're looking from a superior view. This is the left kidney. See how the peritoneum is reflected between kidney and spleen to form the splenorenal ligament, this one, and spleen and stomach to form the gastrosplenic ligament, this one. They are all double fold, double layered ligaments. See, this is a double layer ligament. One belongs to the red and one belongs to the blue. And this other one, the gastrosplenic ligaments. There are structures running through these ligaments. We will study these with individual organs. But I'm just showing you an example of what the peritoneum does. These are two other ligaments. See, this is the lesser sac here behind the stomach, and this is the splenic extension or recess of the sac. Okay, there is another inferior extension that you can go with to make your own way between the layers of the greater omentum. This is the inferior recess, and this recess here, we are in the gastric recess, which is the main part of the lesser sac. You see that? Okay. Special regions, like the region below the diaphragm, it's called the subphrenic space. It's separated into right and left by the falciform ligament. It's not showing here because the liver is being reflected upwards. So we have a right subphrenic and left subphrenic. Left subphrenic with the fundus of stomach and spleen in it, and the right side is the liver and the upper part of the suprarenal and kidney. See the subphrenic space. At the front, there's subhepatic space. We are now at the right side of the subhepatic space, which is the hepatorenal recess. This is the right kidney. And the left part of the subhepatic space, which is the lesser sac itself, see? And they are connected to each other. Okay. The last thing to talk about, of course, I told you peritoneum is not over. With every organ, we will talk about its peritoneal features. So it's not over. And in general, the peritoneum supplied by the parietal peritoneum, it takes from parietal vessels, and the visceral peritoneum takes from those branches to the viscera. And the nerve supply, the parietal peritoneum sends through somatic nerves like the lower intercostals and phrenic nerves. And somatic pain is characterized by being sharp and localized. The pain stimuli for such somatic sensations are mechanical, like injuries, chemical injuries, and thermal injuries. All these stimulate pain at its maximum. The visceral layer, on the other hand, is sensitive to different kind of stimuli like distension or spasm or ischemia, and it's carried by autonomic nerves, so it's not localized. The pain coming from them is not localized, it's vague. And this is what happens with any colic, that first it starts into a vague pain spreading all over the anterior abdominal wall. Then by time it gets localized to an area where the somatic nerves start to kicks in and start to be in action. Okay, this is what we can say about the peritoneum in general. I wish you came out with the maximum benefit from this lecture, and thank you very much for watching.